I did my fellowship here at UH in 2019. I'm an anesthesiologist, an acute pain physician for almost 15-20 years. Then I switched to chronic pain in 2019, where I did my fellowship here, so I am familiar with UH and the whole team. And now I'm in a metro hospital. So I have been using the BNS long time, from 2016 or 2017, other system. And like as acute pain physician, so I use ultrasound a lot. So when I switched it to chronic pain, I found it very appealing to use ultrasound, and peripheral nerve stimulation was very close to what we do in regional anesthesia. So this is my main interest now, academically and clinically also. So we're gonna talk about just the technology and the main 5 core nerves. And definitely we'll talk about some peripheral nerve stimulation, and we can discuss any other logistics, not only related to exact system or the exact nerve target, just generally about peripheral nerve stimulation. It's a big part of your success, not only like how to place the needle and how to boost the lead, just the patient selection, how to manage pre-op, post-op, so you can ask me those questions also, but it's not in the core, like a curriculum here. So there's the Freedom BNS system with the Curonix. So to have like understanding of the system. So it is cleared under US product code, and the system uses a high frequency electromagnetic coupling, which is HFEMC technology. This is make the major big advantage and the unique feature of this product, the EMG, the electromagnetic coupling. So this allow having a system without any IBG, and just delivering all the data, all the magnetic coupling outside through the skin to the lead itself. So to understand the system, so you have a lead which have 4 contacts or 8 contacts, which is like simply just the plastic wire that have the contact inside it. To have the whole system, you have to put the receiver inside it. So it have to have, this is the lead, and inside the lead you have to put the receiver. Without the receiver, this is not functioning. So you have 2 components, which those 2 components are the implanted system, which you're gonna put it to the target, and then to use this system you have to have an external device, which is the transmitter assembly. So this the transmitter assembly, it have the antenna and also the transmitter. The transmitter have a battery, and usually we give the patient 2. So when you use one and the battery is done, he can charge it and then use the other one that he have. So no interruption of this use of the system. And then this is the antenna, which the piece that send the EMG signals to the receiver, and the receiver is inside the lead. So those 2 components, they are the implantable, and those the external transmitter assembly. So this is kind of what it look like. So proximally or distally, proximally here you have the contacts, and the distance is just less than 2 millimeter diameter, small contacts. And then proximally here you have the tines. So this is the permanent lead, because there's other lead does not have tine, which we use it in the trial. So those the tines, as you see, like they are hooked to the tissue and prevent the migration, but only like proximal migration. So simply if you put the lead and you pull in the lead, those tines will hook to the tissue and prevent the migration, but not proximal migration. So let's say, for example, if there is forward movement in the lead can sneak in the tissues and still move between the muscles. So those are the tines. And then proximally to the tines is the microchip, with the ASIC chip. So this is, you can name it like as the brain of the stimulator, as the main center point of the stimulator lead, which all the programming happen here. So when you program the external programmer and all the changes, it happen at the microchip and the ASIC chip, which receive the signal there. But again, you have to have the receiver inside, the receiver wire coil inside. The microchip, the diameter of the microchip, as you see, it is the thickest one. And also internally diameter, if you get a cross section inside, Inside here, the diameter of the internal lumen of the lead, because the lead have like inside, when you can see the leads here, there's like a small lumen inside where you're gonna put your receiver wire inside. So even at this area, the internal diameter of the tube inside the lead is smaller a little bit, because when you push the receiver wire, when you push it and reach the receiver wire, reach the area of the microchip, it's a little bit tight. So sometimes you find resistance when you're putting the receiver inside here. So this is simply the distal, how it looks like. So this is kind of the whole electrode array. So usually when we have it in your kit, it comes with the blue stylet. It's simply just a stylet, just a simple stylet. You can have a curved stylet, you can have straight stylet. I think the green one is the straight.
Correct.
So the green and the blue, it have a little bit of a curve. It sometimes help you directional when you're pushing the lead. And once you satisfied, you put the lead in the correct place, you have to remove the stylet and put a receiver. So the receiver, it is not a stylet. It's just a copper, not gold. There's some rumor it's gold. So it's a copper, you put it inside, it's very flimsy, very small, and sometimes it takes you a while to manipulate it and put it inside a small opening. You have like a good eye to put it inside. We're gonna show you some tricks and trips how to put it easy inside the lead. And it's very flimsy, so it can kink, so try not to kink it. And the kit, we also hopefully go through the kit and show you what's inside the kit, the temporary and the permanent, so you're familiar with it. Usually it comes with 2 receivers, so each one lead have with 2 receivers. They know that you may be kink it, so they have another one. So without putting the receiver, it is not still a stimulator, it's not an active stimulator. So you have to put the receiver to have the whole neurostimulator. Okay, so without it, it's just simply a plastic piece. You have to put the receiver, which will receive all the signal, and having this wire or this lead will be functioning at that time. So this is also simply how it looked like, an example of what your steps or how it looks like. So for the trial, I will see an example. This is your target. This is like the genicular nerve, the inferior medial genicular nerve, or the saphenous, the infrapatellar saphenous. I'm gonna go through some differences, but this is give you idea how the system or the first incision or your second incision will be. So let's say will be a trial. So this is your target. So ideally we put the lead maybe across the patient. Okay. So this will give you a good, like a 360 view of where you're gonna have your lead as a target, and when you're gonna enter with your needle, and when you're gonna have your receiver. So if it's a trial, don't worry about the receiver area. So let's see, this is your target, and you want the contact close to the nerve. So your entry point, ideally, is around the marker band, the receiver marker band. So the lead, again, here is the contact, here's the time, and you have a small plastic, like a metal silver and another silver piece. They name it the receiver bands. So the first marker band and the second marker band. So the first marker band, which is close to the lead itself, the contact of the lead. And then the second marker band, we name it the receiver marker band. So the area here between the first marker band and the second marker band, which we want you to start your needle or to have your first incision. So you enter, you put your lead at the target, you're happy with your confirmation of the location that your lead close to the target, and then your second incision, if it's a surgery, will be distal to the second marker band. So all this area that it's distal, or you can maybe proximal to the second marker band, is considered like a dead space. So the only active part is the area between the first and second marker band, or the area of the microchip. All the areas here proximally, you can cut it, you can customize it anywhere you want. You can do this coil to make the receiver area stable and the tissue is like anchoring, but it's not an IBG. Is it clear? So this is the. So if you're gonna do a surgery,
So you'll be threading your lead all the way until the second marker is under the skin, correct? So when you're trying to place your lead, you need to make sure both of them are proximal. It's not like you do one proximal, one distal.
so the first one, the area between the first and second one, it will be under the skin. But your first incision or your entry point will be around the first marker band, or like between the microchip and the first marker band, or just proximal to the first marker band. So if, let's say this is your first marker band, do you have another slide with more clear actually? Because they send us not the full, they did not send us the full ones.
So you lay it on the skin,
Right.
and you can see kind of where they are in relation to the fluoroanatomy, and you're like, okay,
They
my
have other
needle's gonna be
slides,
Yeah.
somewhere here to here,
And then you
drive, right?
But what I'm saying is like you keep threading your lead
Yeah.
through the needle, and then you need to make sure you're past that second marker there, or not
They did
necessarily.
not send us the whole.
Well, so Adam, the copper goes all the way up to here.
To the second receiver marker band, yeah.
So that one.
Okay.
So
After
then,
that, it's
so then it bottoms out,
Mhm.
and then
They
you
could
trim
go
it
up
here, and
and
you gotta keep this straight so the
Straight
so the
induction pad
Okay.
can work.
Right.
We're doing one lead for this.
This
Not
is-
works, not works.
Goes this way. Then you can put the other one.
I think there's, remember, you have one slide with the whole procedure. So maybe this is a little bit more clear. You see this one here. So here was your ideally the first incision. Let's see, this is the full surgery, not the trial. So for the full surgery, you have two incisions. So the first incision were around the first marker band. So it doesn't have to be exactly at the first marker band, but this is the 4 contacts. Here will be the tines, and then here will be the ASIC microchip, and then there's a small distance in the lead, and then the first marker band. So your first incision, which is your needle entry, if you want to go with the needle first, we'll do the incision first. So your needle entry or your first incision will be between the area of the microchip and the first marker band. So this is where you want to enter your needle and locate it, and then here you can bend it a little bit, because here the contact and the tines and the microchip, you cannot bend this area of the lead. Once you are around here between the first marker band and the microchip and around the first one, you can do some bend here. It depends on the anatomical area that you are, but don't make like a big bend, like less than 90. If it's like 30 degrees, 45 degrees, acceptable. If you do more than that or like close to 90 degrees, you risk migration very strong, and also you can like fracture the lead and so make a small bend. And if you're gonna do a bend, take a suture here, because it's gonna move very quickly. Once the patient out, you're gonna move very quickly. Even with the tines, it's gonna move. So try not to have like bends in the lead as much as possible. Make it all straight, but you can still bending like suprascapular. We're gonna go through the target or infraclav. If you do bend here, do it like a small bend and take at least one suture with non-absorbable at the area here. Then your second marker bend. So your second marker bend, which we name it the receiver bend, because it's closer to your subcutaneous pocket, which you're gonna do for the receiver coil. So the area from the first to the second, either you want it to be
So
straight.
this is the first one, you put and this is the second. Okay. There you go.
Yeah, exactly. So just to clarify things, here's the lead, which are around the target nerve, and you have the tines, and you have the microchip. Then you have two marker bands. The first marker band, second marker band. The first marker band, you see the two, but sometimes is one. So one or two, and here also the second receiver band. The difference one is just to identify this lead A.
Different channels, so we can
That's
program
it.
these independently.
So just to differentiate, this is the lead A or lead
Yeah.
B. Nothing is like easy about it. So the area from the microchip to the marker band, you can have your incision here. So when you land in the patients, you having to plan. So if it's your target here, so I put it here, and then my first marker band. So my first incision will be around here. So I'm from this area around the first marker band. And then the distance, the area of the lead between the first and second marker band, try as much as possible to make it straight. As much as possible. I mean, a little bit of angulation is not like a big deal. They may not like that, but it depends on the anatomical location. Try to make it straight to, having high chance that it will not interrupt the receiving of the signal, because the signal that is gonna come out, ideally, they're gonna be received by this area. And then this is your receiver marker band. Anything distal to this, it's like you can do anything with it. Consider it as like dead space. You can customize it, you can cut it, you can make loops to just anchor it, because you remember you have those tines and they prevent the proximal migration, but nothing is like distal migration. And also you want the area from the first to the second marker band stable, doesn't like migrate and move somewhere, it depends on the location. So ideally, again, your first incision will be here, the second incision will be around or distally to the other receiver band. And then at the receiver, when you see this receiver coil, you want to make it stable in the tissues. So you will create a bucket, like a small bucket. Your second incision will be, like a 2-3 centimeter, 1.5 inch, and you want to make this stable in the tissue, and also not only stable in tissue. Let's say if you cut it, just like a sharp tip like this. So sharp tip subcutaneously, they can have erosion and just come out the skin because it is sharp there. So you want to make it smooth and also anchor into the tissue by non-absorbable. So the most they recommend doing like a coil, as you see here, like do a couple of circles or ovals, and then stabilize this by suture. So you can take 2 sutures to make it like this, like rounded. Take 1 suture here, 1 suture here to keep them like this shape, and take another suture in the other side to stabilize it in the tissue deep, to make it like a bucket, small bucket. So this will make it stable, will adhesions and fibrotic, and it will be stable in the deep tissue. It will not move, and also it will not erode through the skin. Sometimes I found it like like time consuming to do this, and you have to do a lot of sutures. So do you have sutures? You don't have sutures. So what I do, I simply take a suture at the end here and suture proximally and make it like this only. Because you can take sutures through the lead itself, but anything proximal to your second receiver band. Even you can take sutures through the lead itself to stabilize it.
So you make a bend at the end and suture through it, and then into the fascia, basically.
So
we don't tie and cut. But
Yeah.
we were tying.
You tie a knot first before that part.
So surgically, we can show you. You make incision here, you put your lead. I recommend doing a suture at your entry point here, your entry point, because you can have angles here. The lead can move a little bit, so I will do 1 suture here.
You're saying this is a suture through the lead?
Here, no,
Yeah, okay.
because all this is the active part of the lead. Don't suture through it. You will just suture around it to stabilize it to the tissues deep.
Okay.
And don't make it super tight. If you super tight it, you can affect the conductivity and you can bend it. So make it like decent to make it stabilized. And then you do your second incision here, and you will tunnel the lead from your first incision to your second incision. Like just simple tunneling, and usually the distance is short. And once you get this out, and you're gonna put your receiver. Don't forget that you have the receiver inside the lead. You want the receiver, which is the small tiny wire inside, the copper. And if this small copper move, you may lose the ability to stimulate the lead. So we want to be sure that this copper inside is stable. So what we do is just a simple knot. So you will do it like just a very simple knot. Tight, very tight. Can I tight?
Yeah.
Or you will like tight, just a simple knot. So this knot will keep the receiver stylet, or not stylet, the receiver wire inside the lead so it doesn't move. And then you can do anything with this part. Cut it, do those coils that they recommend, and suture to the tissues. Some like you can just do it simple turn like this by taking a suture through the tip and suture here, and then suture them together. So to make just a circle, and then suture to the anchor to the tissue. Use non-absorbable suture. By doing this, you are stabilizing the proximal end of the lead so it doesn't move, and also you're keeping the receiver inside the lead and prevent it from migration. And ideally, and then this is just the lead after you implant it, then you want to use the WOW, or the external transmitter assembly, which is this that will transmit the antenna, that will transmit the electromagnetic waves to the lead inside. So where are you going to put it? Ideally between the first and second receiver band. But the majority of the targets, the microchip itself, it's superficial. So it still can capture the electromagnetic waves. So you can put the wearable directly over the microchip. Ideally, you see like around 4 centimeters is the distance from your external device to the lead itself, the receiver in the lead, to able to capture. So 4 centimeters, 2 to 4 centimeters. But they can have a new WOW. Now it can go up to 6 to 8 centimeters. So this will allow the patient to have the WOW above the clothes. It doesn't have to be over the skin, because sometimes it's annoying to do it over the skin directly. So they can wear it over their clothes, and even if the microchip and the receiver, while in the lead, is deep, you can still transfer the energy. Let's say you use it for the like spinal cord stimulator, or cornea, and the patient BMI is big. So your antenna gonna be deep in the tissues, like 4, 6, 8 centimeters deep in the tissue. So you may able not to transmit the signal. This is the idea that why, because you can say why having this area. I can just stimulate directly over the microchip, because many target this microchip is deep to the tissues. So the signal may not able to go through the skin, to the tissues, to the muscle, to stimulating the lead. So that's why this area between the first and second receive marker band, it should be a little bit superficial, 2 to 4. But with the new devices, it can be even deeper. Keep going, or
Yeah.
let me go to the original lecture. And as you see, the beauty of this, it is very small, and you can customize it to different patients. Like in acute pain, we do like a nerve catheters. So it's small, you can customize it to enter from above, below. It's not like a standard like a spinal cord stimulator.
Sure.
Or big leads. You see, just like a small, tiny. You can customize it going from up. Patient have certain anatomic difficulty from above. You can. I mean, the recommendation try to keep it straight, but a little bit of bending, it's like acceptable. So even there's I know some they even do it up.
If you have
With
like
a
a
tibia.
target in the forearm,
Forearm
you
or
can, you
tibia
can
or-
view the lead,
Oh, okay.
so it looks like that.
As long as these.
As long as the stair is straight, exactly. Yeah. Or if you're running two leads, like both cluneals, and you have the opportunity to L them and run them together, that's fine.
It's very customizable and allow you to be like a creative. You can do it from right, left, left, right, up, down, turn it around. So it's a very unique. And the MRI conditionality is also very important characteristic. So it is MRI condition up to 1.5 full body Tesla, and I think they are working to make it 3 even, but now it's up to 1.5. So patient can get the MRIs, no issues with that.
3 for our spinal cord leads, 1.5 for our
Yeah.
peripheral leads, but we are, like you said, we are working on getting 3 for our peripheral leads as well.
Yeah, so they are approved as spinal cord stimulators and peripheral, but the focus mainly on the peripheral nervous stimulation, which like have unique characteristic for the peripheral nervous stimulator. But you can implant it for spinal cord stimulator, or you are on label, you are like, because it's approved for spinal cord stimulator. If the patient doesn't need a battery, so I think it's be a good decent target. So which nerve targets? So the nerve targets simply like if you can name any nerve in the body, anything below the head, anything below C2 and below, this is like approved, FDA approved. Craniofacial is not approved. If you want to do craniofacial or like above C1, C2, it's off-label use. So anything below any nerve, you can name it, and you think this is the nerve is the reason for the patient pain, and you're able to put the stimulator in, you can do it. Any nerve in the body. So that's why even like when they teach the courses for the PNS, it's difficult to teach all the nerves in the body because simply you can put any nerve in the body. So the focus with the company about the main core nerves, 5 nerves. Those 5 nerves will cover you 60-70% of the whole pain targets in the body. The majority of them are good targets by fluoroscopy only. You don't have to have ultrasound experience, or even you don't have to have ultrasound in your practice. So majority of them are done by fluoroscopy. So those 5 core nerves is the focus. So those we're gonna cover them, and then after that we can cover any nerve if you are interested in. But we have to cover those because this will give you in your practice the majority of the nerves comfortable with just fluoroscopy. Suprascapular, I mean the majority of the shoulder pain that's very common in your clinic, shoulder pain, so suprascapular, and you can do it only